Thank you very much, Dr. Swapna, for having me in your course, and it's always a pleasure being there. Well, I'll be talking about both the commonest performed refractive surgeries, and that is the ICL and the laser vision correction. And one of the problems in both of them could be a rise in the intraocular pressure that we have to see. The morbidity of glaucoma among myopes as such is 2 to 3 times more prevalent than in the general population, and majority of the patients that we are correcting by laser vision correction as also by the phakic implants are myopes, and therefore we have to be careful that we do not compound their problem. Now let us look at the two things first. First is the laser vision correction, and then I'll go to the phakic implant. In laser vision correction, the only reason for the pressure going up is actually the steroid drops, which are commonly used. Those surface acting steroids are more often used, and they are used for a smaller time. We need to use the steroids for longer periods when we are doing surface ablation. That is the PRK or the trans PRK that we are doing. Now, also there are several studies which have shown that patients with high myopia have a greater risk of being steroid responders. That is there. So there is no way that we have tested out whether they are steroid responders or not. So we are commonly using steroids in all our post-op cases. And the manifestation of steroid-induced glaucoma is similar to primary open glaucoma, except the fact that the pressure tends to rise very significantly at times. Now, myopia as it is more vulnerable to elevated IOP as regards damage to the optic nerve head. Now, one of the common things that happens when the pressure tends to rise is that the patient comes back to you and comes back suddenly saying that my vision has gone down. I was seeing clearly after the surgery, and 2 weeks, 1 week, 3 weeks after the procedure, the patient says that my vision has suddenly gone down. And then what happens is that if you are a novice, you will put that patient on a slit lamp, see, and you will get like a haze. And this is similar to the picture of the DLK, and often this mistake has been done that it is DLK and you start putting more steroids onto the eye, and that is something that is going to cause a problem, and it is going to be, obviously, apart from being ineffective, it will aggravate the corneal haze. Now, Goldman Application Tonometer is the gold standard for IOP measurements that you have. And because it is based on the modified imperfect formula, the important thing is that when you have done the laser vision correction, the cornea thins out, and the pressure reading, therefore, the principle that is there in the imperfect is that it assumes that the cornea is dry, infinitely thin, and perfectly spherical surface with a diameter of 3.06 millimeter and the CCT of about 520 microns. And the thinner the cornea leads to an underestimation of the IOP. And this table, you need to know that when you're looking at the pressure, so sometimes you should not miss out the pressure. One is the confusion with DLK. The second is the IOP correction that you are not doing. Because the patient's cornea has been thinned out, and if you don't do the IOP correction, so you might say, okay, the pressure is 18 or 20, and there is absolutely no problem. So you have to have this correction table in your mind. That if your corneal thickness has gone down in this particular case, if you have done a correction of 8 diopters, you will have to add a +7 or a +6. Now, also what happens is that the corneal flap interface fluid after LASIK, that also caused a lower IOP reading, and that could mask a dangerous elevation in the IOP, because whenever the pressure goes up, the interface kind of has fluid coming into the picture, and that is the problem. And we have also personally also reported interface fluid syndrome, and that could last for long, which has been reported by these Chinese, but in our case it tended to settle down, and that is something which can again cause a fallacious low reading of the IOP. Now, the treatment obviously is that there is no specific protocol. It will depend on the pressure, but these steroid responders respond very well to anti-glaucoma therapy. If you have diagnosed it well, you have just given them acetazolamide, you have given them few drops, they will next day they will clear up, and they will tell you, the patient comes back with a smile in their this thing. You just need to do the stoppage of the steroids and to give anti-glaucoma treatment that is there. So that is all that I'll wish to say, the common fallacies of diagnosis and the treatment, and why you get it in post laser vision correction. Now let us come to the phakic IOL. And there are again the steroid responder is one of the things, because there also you are giving steroids. The number of cases that have been percentage has been reported as high as 0.8 to 26.2% that is there. So first thing is to prevention is by sizing the ICL or the phakic IOL in the proper manner, because if the vault is too high, under those circumstances you are pushing the iris up and the outflow channels are therefore are going to be compromised, and that is the biggest problem. Gonioscopy should always be done before you are doing a patient for an implant. And you should also look at the horizontal wide to wide. There are obviously several theories as to whether you do a UBM, whether you do a pentacam, or you do a caliper, but majority of us use a caliper that is there. Now, the position of the ICL in the ciliary sulcus, that increases the risk of non-pupillary block. So it's not an angle closure glaucoma, it happens, but the whole thing is pushed up, that is there. Pigment dispersal, if you have been poor as regards your surgical equipment and you have pigment dispersing, that is the problem. Design of the ICL is also important. Now, almost all the phakic implants are having a centraflow or a central hole, by which could be 360 microns, or there could be paracentral holes also. When the companies came out only with paracentral holes, I would still do a peripheral iridotomy and not leave it, but a centraflow, you don't need to do a peripheral iridotomy in these cases. Now, these eyes would therefore, apart from the compromisation in the outflow, also the steroids are there, and they become therefore more prone to an angle to the pressure going up. Now, pupillary block can also be there, which obviously, if you have not done a peripheral iridectomy in the older versions, or where you don't have a central flow, that is going to be a problem. So always we used to do a peripheral iridotomy in these particular cases, that is there. An inverted phakic IOL will cause cataract if you put it upside down, but it is unlikely to cause glaucoma. But the inflammation that can be induced and the iris chafing, etc., that is there, that can cause a problem. Now, this is one of the cases. 34-year-old male patient is using bilateral contact lenses, wanted refractive surgery. Pentacam was 512, but the power was very high, minus 10.5, 12.5. And the corneal thickness, pentacam was 512, and the corneal thickness on OCT was 477. So preoperative parameters were fine. There were no echoes in the anterior or posterior chamber. Angle is open 360 degree. Wide to wide measurement was done. Both eyes, this is the older version of the IPCL, and both the eyes, YAG iridotomy was done. You can see the YAG iridotomy. There is some pigment dispersal that has happened. And after the implantation, you can see that the pressures went high. 11 day, 13 day, 14 day, 15 days, and the pressures were not controlled despite full medication. This is the anterior chamber analysis. You can see that the vault seems to be all right. And this is 375 vault. So it is actually not a high vault at all. 13 day, the vault actually tended to keep on going up. Now, what is the reason? Is there some hydration in this material, or what is happening? The vault to start with was fine, but on 13th day it kept on increasing, and the pressures went up at that time, and the corneal edema won't subside. Acetazolamide, because it was a vault, and we didn't, the steroids were continued as loteparednol instead, and IOP, despite full medical management, could not get under control. So despite all this, maybe we could have thought of stopping the steroids, but then this is what the condition looks like. And we will go ahead and this is the entry that one is doing. You can see that there is no central hole. These are paracentral holes, and I said that I do not believe in these paracentral holes giving you, because they touch the paracentral and they're below the iris. So one goes in and removes this IPCL. You can see that holding it, nudging it out, and then under those circumstances, just doing holding, grasping it, and it can easily be pulled out from the incision that is there. And then just remove the viscoelastic which is there. And you can see that the IOP normalized on 3rd day post-op. So it is not a steroid-induced glaucoma. I really can't say as to why the vault kept on increasing and why the pressures were so high. But this is what it is. The etiology and management is being discussed by this paper by Dr. Somshila, Jagdish, Praveen, etc. And what they said was that the mean intraoperative angle, this is the age that is there, male, female, refractive errors, which is there, gonioscopy, 15, 3 eyes had increased, trabecular meshal pigmentation, and the angles were, however, open. Anti-glaucoma was the last follow-up. You could see that they also had a reasonable number of patients, but I can't give you a specific reasons as to why I had, because there were no pupillary block, as they said. There was one case with the malignant glaucoma. So these are complications of glaucoma that have been noted with an implant, because you are crowding the anterior chamber and putting a lens, and there could be various mechanisms which can work for the rise in the intraocular pressure. Retained viscoelastic square and overfill could be one of them, especially if you are using viscode, etc. Pigment dispersal, and you could see the pigmentation on gonioscopy. Increased high vault is something there. Long-standing high vault can definitely cause peripheral anterior synechia. Oversized ICL, need for a good preoperative evaluation, because if you oversize, the vault will go up. Oversized ICL would cause excess vaulting, and if it is more than 750 to 1000, you definitely need to take out the lens, and this can be confirmed by the ASOCT. Pre-existing juvenile open angle glaucoma needs to be ruled out, and in very few cases it has been reported that malignant glaucoma can be there, and that diagnosis can be made in the absence of a pupillary block and excess ICL vaulting, and the ultrasound B scan has ruled out suprachoroidal hemorrhage. So that is when you will call that malignant glaucoma. Ciliary body irritation and inflammation by the sulcus placed ICL has also been known to cause anterior rotation of the ciliary body. So this has been a hypothesis that has been proposed by the same group from LVP, that this is possibly the reason that the ciliary body irritation and inflammation by this lens led to a rotation of the ciliary processes, shallowing of the AC, and aqueous misdirection into the vitreous cavity. So this has been one case that they have reported about malignant glaucoma. Steroid response, as I told you, can happen, and this would require stoppage of steroid and anti-glaucoma medication. So to sum up, I would say post-operative steroids and underestimation of tonometric IOP are extremely important considerations, specifically in the laser vision correction. Keratorefractive surgery influences the accuracy of the measurement of the GDX. That is something also important of the RNFL, but there is no significant change in the RNFL measurements after LASIK using GDX apparatus that is there. Glaucoma medications in the management of patients who have had keratorefractive surgery are similar to the medications used in other glaucoma patients, and with newer models of Centraflow, the problem of having incomplete PI or a pupillary block, etc., that may not be there. However, all the causes of IOP would still be a problem, and that you need to look at in these particular cases. Thank you very much for your kind attention.